Hey, everybody. Welcome to In the Know with Nina. I'm your host, Dr. Nina Crowley. I'm the Director of Clinical Education and Partnerships at SICA, where we partner with healthcare professionals and clinicians to offer body composition solutions. Today, I'm really excited to be joined by Sarah LeBrock. She's the founder and director of All About Obesity, which is a non-for-profit obesity organization founded to be a trusted go-to resource for anything obesity related in the UK. And recently, you may have seen her on the expert panel around the commission from the Lancet report, offering the patient perspective. So I'm really excited to have you here, Sarah, to talk about the patient perspective and sort of your take on all of this and really get into the reason why we're all doing all of this care is for the patient.
Yeah, no, thank you so much for inviting me. As always, happy to kind of share my own lived experience in this, but just to kind of delve into the conversations of topical things that are going on because I think it's important and such a changing environment at the moment. So many things are happening and it's exciting. So thank you so much for having me along today.
Yes, it is. It's exciting and it's also so overwhelming. We haven't had much movement in this area prior to a few years ago. It was pretty stagnant. So tell me kind of, I know you had that real-time experience of being there as they discussed the Lancet report. You were able to offer your patient perspective of the lived experience. And so if anyone didn't catch that, could you maybe share a little bit about that? And then we can kind of go into more of that nuance.
Yeah, for sure. So, obviously, the Lancet Commission is giving a perspective of how we can look at measuring someone living with obesity beyond BMI. So, kind of looking at what that diagnostic indicator might be. And unfortunately, we're not at the stage of having like a blood test or something or a biomarker or something that simple yet. I hope in the future we do because I think that would make life so much easier. But I think for now we have to work with kind of a bit more of a broader kind of spectrum. So the commission is looking at people and their body fat kind of composition. So they're looking at kind of where that might be, and then looking at things like waist to hip ratio alongside BMI to kind of then see that as a marker of whether someone has impaired health or not as a result of kind of their body shape and size. So I think it's interesting, and what's been interesting is since the commission and since those conversations is hearing lots of different conflicting views. Like I think it's been quite polarized, the conversation actually. So on the day it was very much like everyone was very excited and it was like, oh, this is great. And I think it is great. I'm not taking that away at all. But I think there has been some like, but what does that really mean for the future and for right now? And the fact that we can't really 100% measure things. So are we going to miss the people getting treatment because of this? Or are the wrong people going to get treatment because of this? So I think it's opened up a lot more questions than answers to some extent. Because at the moment, the commission is saying that there's something called preclinical obesity and clinical obesity. So people with preclinical obesity potentially might have a BMI that fits into the obesity range, but doesn't have maybe any complications going with that. So, maybe no hypertension or no comorbidities or no kind of indications that their health's been impaired by their weight. So they would sit in the preclinical group, and then I suppose potentially deprioritize for treatment right now because it's maybe seen as like, do we need to be treating these people? But again, I think that's a question because actually, should we be treating these people? Because prevention is obviously another thing we keep looking at. So it's another conversation. And then the clinical obesity being people that have got higher BMIs potentially or health in kind of comorbidities off the back of the fact that they have excess adipose tissue and kind of where that sits around the middle and the kind of implications that has on health. So I think it's definitely opened up lots of conversation for people. And I think there's lots of ways around this. I think right now when we're in a space, and I think similar in the US, I know you have a different kind of healthcare model in the US in the fact that it's kind of driven by insurance, etc., health insurance. And in the NHS, we have this access to care for everybody through the NHS so that we don't have to have the insurance side of things. We're very limited to the amounts of funding available to support people getting access to the medications, for instance. So the conversation I'm having all the time is how do we prioritize? Like, what does that look like? And that's quite an uncomfortable conversation to be a part of because in my eyes, everybody that lives with obesity should be able to get access to these medications that can potentially change their lives. But reality is there is only a limited pot of money. And so how do we prioritize people? So they're going for people with like the most need. So things like if they're people with cancer, for instance, that maybe need to lose weight to have surgery or treatment,
Hmm.
things like IVF, or fertility kind of scenarios, and various other kind of conditions that we're looking at as prioritization. But I think it's definitely opened up conversation. I don't know how you feel over in the US as well, but that's kind of where we're at in the UK for sure.
Yeah, it's interesting because I think, the goal is really to help put some better structure around the diagnostic,
Yeah,
where we use BMI inappropriately as a diagnosis tool when it really just was a screening tool. And that, kind of differentiating between different body compositions, really, to say someone could have excess adiposity, but really no clinical impact of that. No, they say organ damage or no, other health conditions related to that. And is that inherently bad if someone is carrying excess adiposity? Here, where I do think it's important is to think that the preclinical, is really like pre-diabetes, in that we're not saying that's still not prevention, right? So they still have something more than someone who has no excess adiposity. We do need to think about what that means for treatment or intervention. And really, I do think we're opening up the nutrition, behavior, lifestyle, along with now medication and surgery options. It's becoming, I think, more the spectrum of care is easier to access in that realm, because before you would have programs that were just surgical, just medical, just nutritional. And I think we're seeing more of those kind of overlapping and understanding people need access to all the different components potentially.
yeah,
um, and then when we get that obesity, clinical obesity diagnosis, I think the goal was really to help legitimize, or help people understand that obesity is a chronic condition and it has these impacts on health. So
yeah,
I do see in the kind of in the in between of that, where some people are saying, okay, this is a trouble. Maybe they will restrict care to preclinical obesity if they have to make that decision. So I
hmm,
also, with you, I took that approach when I first heard all of the details. Like, this is fantastic. I didn't think of that side of it. Of course,
yeah,
restricting access to care is a problem. We don't want to put up any more barriers to the patient. And for those people who know me, I did bariatric surgery care for almost 20 years. And so we were living in all of these restrictions to surgical care. And so I really was hopeful that with medications, kind of filling that treatment gap for people who were at earlier stages of excess adiposity, that there would be less rationing and kind of, putting up barriers. But that was what I dealt with for so long in bariatric surgery, was policies that said you have to do this, you have to see this person, you have to go through this, and all of these, sort of restrictions before they're allowing access to the thing that would be helpful, knowing that, long term, everybody who's struggling in different ways will need different parts of that program. They might need
yeah.
nutrition more at some points, behavior more at others, exercise more. So, kind of putting that back into the clinician's hand to say, let's take that individual and decide what their particular needs are and assemble a treatment plan based on them. That's what I think the goal would be for most of this.
Yeah, no, I agree. And I think just touching on what you've said there around kind of there being barriers in the way, I've always kind of described it as like it's like we're being made to jump over lots of hurdles before we can get access to care. Like, and I find that bizarre because what other kind of therapy area or kind of disease state would you have to get someone to prove their worth before you actually treated them? And I think this happens a lot around historically like bariatric surgery, saying that people have to lose like 5% of their body weight before you'll give them bariatric surgery. It's like, well, the reason they're there is because they're struggling to do that. I've been part of research for clinical trials more recently, and they were still trying to bring that in, and I'm like, we have no kind of evidence to show that this actually has any impact on that person if they are showing that or not. So why are we doing that? Why are we making somebody struggle just to prove something that doesn't shouldn't be proved, And I think in
Yeah.
obesity, it's so the stigma is so rife in so many ways that people just don't see it. all the time anymore, I think, and because we're so used to it being there. But actually, it's about calling that out and saying, actually, this isn't okay anymore. We shouldn't be making people jump through all these hurdles. We should just be looking at, they have a chronic condition. How can we treat and support them with the best thing for them at that point in time? And I think, hopefully, things like this will start shaping that a little bit further. But we'll see. But yeah, it's definitely an interesting space for sure.
Yeah, and even thinking about, as you said, rationing, sort of prioritizing care. If we're really looking at the research, I think a lot of that will tell us that earlier intervention,
Mm-hmm.
patients who have an earlier, this is true in surgery for sure, earlier
Yeah.
intervention with surgery helped those folks have better long-term outcomes, actually.
Yeah.
So in that
Yeah.
case, it would almost be, if you had to pick, did you pick the person who was earlier in the disease process because they have a better long-term outcome, better weight outcome, if we were looking at that as a measure of success, not getting the health conditions versus once they've already had them. And so I'm
Yeah.
with you, though. I feel like it is an uncomfortable discussion to say, well, then do you let someone who's at the advanced level not get the treatment?
Yeah.
Where do you make those sort of like, very tough decisions?
Mm-hmm.
Um, it's sort of this intersection of what we learn in healthcare versus the policy of, we have a dedicated budget and we have to help as many people as possible. So I think,
Mm-hmm.
I know that my feeling is always help the people at whatever cost, but I
Yeah.
know there's other people who have to consider that cost.
Yeah, no, I totally agree. I think we forget that actually the healthcare systems are companies and businesses in a way, and they've got to have a budget and they've got to stick within that. And we know they don't do that very well overall. But it's like this is going to create even more kind of situations where they're going to be stretching budgets as much as possible. But I think it's also around looking at the long term kind of benefits of these things. And I think that's what we don't do very well either right now, is because we work, especially in the UK, we work in like governmental cycles, which are like 4 years. So someone
Mm.
comes into government and they've got 4 years to prove their worth, etc., and get policies in place. So they are looking at short-term wins all the time. And I think with obesity, it's never going to be a short-term win. It's always going to be a long-term investment. And then 10 years time, we might see the results and the benefits from this. But no one's willing to do that because it's not going to benefit them in their kind of time in office or the NHS for this budget or year. And I think that's the frustration, is when you can see that actually if we invested in this now, in the future we're going to see huge benefits to, like, the amounts of people with type 2 diabetes, hip and joint kind of operations, and all the other things that potentially won't be happening the same because we're treating people earlier and we're supporting people earlier. But there's just this bit where the reality of that will probably never be, because no one's ever going to kind of take that risk of not having the benefits right now to say, look what we're doing here and now and look what we've achieved. And that's quite frustrating, because I'd love for us to be able to do that for sure, because the spend that we're spending on obesity and all the related comorbidities is crazy. It's a lot of money. But if we actually jiggled that around and started treating earlier, we potentially then don't need to be spending later on comorbidities. So actually it's not about finding new money, it's just about moving money around. And I think again people are struggling to see that, because they're just seeing it as this influx of new things that we have to find money for. But it's like, we're already spending the money, let's just do it differently and smarter. But that's hard to shift people's thinking, I think, around that.
Absolutely. And another point I wanted to ask, sort of from your perspective, I know you're integrated with several of the patient advocacy groups globally. How are we translating this to the actual person who we're trying to help, right? I know there's so much confusion and details when we're talking about translating research and all of that to the actual sort of end user, consumer, client, patient, whatever we want to say. But how is this coming across to the patient? Are they hearing this message? Is it confusing? Is it nice for people to hear that we're not focusing just on weight and we're actually making movements on that? Because I know for so long we've said the words, it's more than weight, it's more than BMI, but then you
Mm-hmm.
still go into a doctor's office and that's really all you're still doing is getting on a scale. I know, in my world, we're seeing a lot more uptake of body composition being part of that discussion. And I do hope that that gets to be a more universal component of a healthcare visit where we're saying, this is one piece of data, until we get those blood markers, like you said, to really do precision. We're getting there with looking at body composition a little bit. So I'm happy to see that supported
Yeah.
as a way to differentiate. But how is that coming across to the patient?
I think it gives people hope that there's a way of, like, we're no longer just a number, that we can be seen as an individual, and that everyone's got a different way of kind of carrying their weight, or how they impact that might have. So I think there's an element of hope. But I think fundamentally, because we've had ingrained kind of conversations, or kind of labels put on us kind of our whole lives around having to be a certain BMI, and you're this, that, and the other because you're at higher risk because of your BMI, or it's hard to come away from that, because I think all of us in our heads are thinking, well, I'd love to not be in that obesity range anymore of the BMI, because that would I literally can't remember ever not being in the obesity range. So to actually be there would be like, I'd feel like that was a huge success. But is that really a success? Because ultimately my overall health right now is pretty positive and it's pretty good. So actually, what does that achieve for me, really, other than, yes, I'm reducing my adiposity in on me, but is that really changing my health overall? I don't know. Like, I think it's all of these things where you just don't know. So I think it's very mixed, because the messaging's very mixed. I think we haven't got a clear direction with where we're going to go with this. And especially, I think, if you're someone living with obesity that's struggling to get access to the medications, for instance, right now, you're kind of probably there going, well, what do I need to do? Like, which part of me has to show whatever my worth, or kind of where do I need to be fitting to in order to get this medication to be able to improve my health? So I think it's still not clear enough, and it's still not kind of there's no real pathway of approach to this to enable people to feel clearer around where they should be going and what they should be doing. So I think hope's a great thing, and I've had hope ever since I've heard about the medications, because I'm like, the whole pharmacotherapy pathway and the pipeline is phenomenal, and I really think we will start seeing a huge shift in people being able to manage their weight in a way we've never been able to before. But for me, it's this bit around the labeling and the understanding of kind of how we're going to get access to these medications, and how we're going to get treated in that meantime. That's still a bit grey and still a bit unsure.
Yeah, and I'm even thinking about, again, people in their middle age or getting older. There's so many years of that messaging to unravel. And so maybe the real benefit comes from bringing up the newer generation with some different guidelines and some recommendations, where they don't start hearing those messages as young as, however young they start, pretty early on, where you're hearing, you're in this red category and this is bad, and all of those sort of, labeling, like you said, that it has done such damage. Maybe we do some damage control for those who are in the category already. But looking forward, and I do know there's, I haven't dove super deep into the pediatric side of this, but I know they do have discussion of that here. And have you looked much through that part, or how has that discussion been with the peds or the children?
So no, so in the UK we have something called the National Child Measurement Programme, which I hate. And it was really just one of these things where it was like a number driven thing to see, like, initially apparently that's what it was, a screening, just to see where we sit with how the weights of children through in the UK. But what that's then used for now is that your children get weighed in reception year. So that's like when they're 4 or 5 years old. And then they get weighed again at when they're about 10 or 11. So before they're going into kind of the secondary school in the UK. And then the parents get sent home a letter basically telling them that their child, is either in normal range or kind of, overweight, and for me, it's like the damage here is like sending a letter like that home to a parent is what they're going to do with that information, like, and what can they do with that information? Because actually, just because a child might be in the overweight range doesn't mean that they suddenly need to be on a restrictive diet, or they need to be on this, that, and the other. But I think there's not enough education around what all of that means right now, and that's what concerns me, is a parent then going to be sitting a 4-year-old or 5-year-old child down and telling them, you need to be stop eating this, and you need to be doing this, and then we're creating this issue with food at that age, Or do we do what I've done, because I've got a 5-year-old and this letter came home saying she was actually in the overweight range. I mean, she's really tall. She never sits still. Like she doesn't like cake or sweets. Like she just eats fruit all day long. I'm not going to let that letter impact me in any way, shape, or form, because I know she's totally healthy and fine. And so I'm just going to ignore that. But I know for some people, like they really would take that really personally and kind of
Yeah.
go, well, what do we need to do? And it's like, they're still growing children. I think we need to just be mindful of, until it's at a point where we can see it's impairing their ability to kind of go out and play or do things that they should be, or if you're seeing that they are eating maybe too many wrong food groups. And I say wrong, I hate that, bad, good, but like eating too many refined sugars or ultra processed foods, maybe, that we need to be a bit more mindful. But I think, yeah, again, it's this pressure to be fitting into a box, and if you don't,
Yeah.
it's bad. And I think that's what we need to come away from, for sure. So if we can educate the next generation to be a bit more open to that, then that would be a positive thing, for sure.
I didn't realize they were still doing that over there.
Yeah.
I know that happened here in the U.S. Years and years ago, but I'm pretty sure the majority have come away from that practice.
I know.
It does just make me think of just how long it takes sometimes for, you know, things that we learn in research or practice changes to actually take effect.
Mm-hmm.
And if we go one way and say, okay, let's do this to help, I don't know, I'm sure there had a point in the beginning to say, like, let's
Mm-hmm.
help people categorize. We have this urge to sort of have an easy number that can apply to the masses versus taking that nuance and that, comprehensive total look at the person in front of you. It's such a spectrum. And I had
Yeah.
that thought here, when I listened to and read through this report from the Lancet Commission, is they really seem to strive to make something that could be applied across, the globe, from a
Mm-hmm.
rural health to, to all, urban, or, different levels of care. It's so hard to find something, right? So I think that's why they focused a little bit on the waist circumference as a measurement that could be done almost everywhere.
Mm-hmm.
Whereas, again, in my mind, I'm like, we do have some better tools. And so where it's applicable, even waist circumference is pretty tough. It varying sizes, or body habitus, where people carry their weight, it can
Mm-hmm.
be hard to get a good waist circumference. And
Yeah.
even verifying that in the literature as a way to measure excess adiposity, I'm sure they did not have the size of people represented in the study to show exactly how accurate that is. I mean, that's a whole, sort of subtopic, but I do know
Yeah.
that sort of the reason for that being sort of advocated for was also to say this could be done most everywhere, whereas
Yeah.
bioimpedance or a DEXA or a more, sophisticated technology they might not have access to in every rural health scenario.
And it's the cost of it all as well, isn't it? I think that we know that there are better measures, like you say, DEXA and all of these kind of things, but they're so expensive. And so the reality is that people won't get access to them. So most people could get access to a tape measure, I guess. And I think that's what they're trying to go for, is like, this could be a thing. But then, yeah, there is the whole, I mean, I've spoken to healthcare professionals over here, and they're very much saying, but people don't know how to measure hip to waist properly and things. They don't know where it, so it's the whole, like, then there's a training piece around what does that look like and all of that. So none of this is 100% perfect, I think, but it's just about how we can try and just move away from this number that we've been giving people, that we know just isn't right and isn't kind of representational of that human being and what's really going on for their health. So I think it's positive we are trying to explore what other things could be, but I think we need to be mindful that it's not the answer, and it's not kind of perfection by any means, and we research will carry on, and the search continues, I guess. But I do think that it's a step in the right direction, for sure, and definitely opened up conversation around health and obesity and what that looks like.
Yeah. And even, with waist circumference, it has me thinking too, in our effort to get a number that can be done anywhere, are we then, like, is that so different than BMI, where it was,
Well,
hey, it's cheap and easy. That's why we're using it.
yeah,
Are we picking something again because it's inherently the best metric, or is it also the 2.0 version of cheap and easy?
BMI.
And
Yeah,
and so
yeah.
I do think we need to think about what are the, in a, in this country even, what would be the next best way to do that. And then I like the idea, again, putting out health conditions, other ways to assess someone's health, other
Hmm.
than just, even other than just body fat percentage, because adiposity is important. But again, in my work looking at bioimpedance technology, we're also able to now look at muscle mass. And so I think that was not in this conversation at all.
No.
So we can say, excess adiposity, that's one factor, but we're also looking at an aging population who can lose muscle mass over time, and that changes body composition. So there's a lot of other factors to consider. I
Yeah.
do appreciate that this, report and this advice, or, recommendations really are, they put up the parameters, knowing that it's not trying to fix everything. It's trying to give, a next level of recommendations and what we can do sort of globally. And then we'll see how providers, clinicians are able to put that into practice, and what that impact is on policy.
Yeah,
We
no,
know
definitely.
we know how
'Cause-
long it took, even here in the US, obesity being, decided to be a chronic disease officially here in 2013. It took a really long time, even for medical records to implement tracking that BMI. And now we're sort of turning the tables and saying, okay, it is a chronic disease. It's not defined by BMI. And so how long is it going to take to sort of undo that, and in its place, put something in that can help better, individualize that care?
Yeah. And I think that in the UK, we haven't recognized that obesity is a chronic condition, but well, the government haven't. It's like they're scared to, because that
Mm.
opens up the door to all these people saying, "Well, I now have a disease, and you need to, treat me and support me." So they've very much been kind of staying on the periphery of that conversation, which I think is interesting, because
It is.
I think they probably want more clarity. And I think that if there was some more, like a clearer diagnostic or a clearer way of defining it, that they might be more open to that. Because I think at the moment they're just scared of the numbers of people that would fit into that box. And they're like, how on earth are we meant to deal with that? But I think it's like we also need to think about those people that living in larger bodies, but actually they're fit, healthy, they're running marathons, they're doing all of these things, and they're saying, they're in their head thinking, I don't want to be deemed as living with a disease, because actually, like, I'm probably fitter than the person that's got a BMI of 22 and isn't running marathon. It's like, so there's
Right.
there's the kind of the other conversation as well, as around people that have been put in this box for a long time and felt really aggrieved by that, because they're like,
Mm.
actually, I'm trying my best to be the healthiest version of myself. I just live in a slightly larger body, and that's now tipping me into this box of obesity, but actually I have no health indications other than the fact I have excess adipose tissue. So does that make me fit into that box? It's like, why am I there? So I think that's what we're trying to kind of come away from, isn't it? Like, kind of shoving people into a box that they don't necessarily feel or should be right now. And it's kind of like this watch and wait approach, isn't it? It's kind of like, okay, well, this is you're carrying slightly more, a bit more adipose tissue. Let's kind of just keep an eye on you and see how things go with regards to kind of any other health indications. But as long as that's all good, then you're good to go, kind of thing. And then other people where they might not have quite as much adipose tissue, but they are showing signs of type 2 diabetes or hypertension or sleep
Mm.
apnea or whatever it is. Kind of, they're the people we kind of focus. And I think that's what the Lancet Commission is just trying to do, isn't it? Is like stratify kind of where we go with that right now, because I think resources across the world like aren't there to just treat everybody. So we do need to have some sort of way of, I hate the word prioritizing, because everybody should be prioritized, but kind of, I suppose, stratifying maybe is the right word, like ways of treatment pathways, and where we start first, I guess. So
Yeah.
yeah, I think it will be interesting to see how this does translate into reality, and what comes from this, but it's definitely opened up conversation.
Yeah, that's an interesting. I hadn't really thought about that, in the way you put it. The folks who are, they do have excess adiposity, and so I think that again begs the question of, like, need to talk to the person and find out where they're at. So someone with excess adiposity who's running marathons, as you say, they're feeling good, they're not seeing any signs of that on their health. They may not need or want treatment, but you also could have someone who, just like we have people who have, cancer that's in their family, they may have family members who they've seen the impact of that and say, okay, yes, I'm healthy now, but I want to make sure that I, get treatment early on because I know what's coming based on genetics and family history, or, some of these other factors. So to me, it's sort of, the beauty is that we went from a system of just very all or nothing. You're either here or you're not. And now we're adding some levels. We're adding the understanding that, there's different personas or archetypes, but there's different ways that you can sort of fit into this category. And we're at least starting to recognize that there's not just one or two paths. So I think, there, like you said, there's got to be some work done and figuring out, taking that information and then having the individual discussion with the person in front of you. And that's what our clinicians can do to say, here's where you're at. Here's, what your personal preferences and values and all of that is. Really that sort of evidence-based practice, putting the patient at the center, help them figure out a plan moving forward. That's how I hope we're able to use this.
Yeah, and I suppose thinking about personalized care as well. So, like, it's not about one size fits all. So it's not like you fit into this bracket, so therefore this is what you have. It's about then looking at that individual in front of you, analyzing their situation, and then making a decision for what's the right thing for them. And like we say, it might just be that that person actually right now just wants to be left to do what they're doing and they don't want any access to treatment or care, and that's fine. And for another person, they might desperately want to, be getting access to treatment and care. So it's about having those conversations and understanding the person in front of you. Because I think we do try and just tar people with the same brush a lot. And I think it's about trying to actually see everyone as an individual and treat them that way. Definitely.
Yeah. Well, I was going to ask if you had any sort of final thoughts, or if you were, talking to a clinician here in the US or elsewhere, what would you want them to know from, someone with the lived experience, how they can approach this in a way that's better than they have been doing in the past?
I think it comes down, I think it's a great question. And I think it comes down to having a conversation with that person and asking them permission around what they want to talk about for a start. I think we need to come back to that language piece around, if you've got someone living with obesity in front of you, are they wanting to have a conversation about their obesity? Because not everyone is. And I think we need to remember that. And then I also think that, treating them as an individual and understanding everything about their life, because you're seeing them as in a snapshot in time a lot of the time. And so, I live with obesity and have done my whole adult life, but more recently I've lost a significant amount of weight, yet I still live with obesity. So if someone met me today, they'd probably be like, right, so what can we do to help you, Sarah? And it's actually like, well, actually, I've achieved quite a lot recently. So it's about understanding kind of where that person's at on that kind of scale or that journey or that path or whatever we want to call it, and acknowledging that and then supporting them to understand, well, where are they trying to go? What are their goals? Because not everyone's goals the same either. Like some people, it might just be that they want to be able to tie their shoelaces without being out of breath. Or just being able to go for a walk for a bit further, or it's like understanding that individual person's needs. So I think that's what I would say is, don't think everyone's the same and don't think everyone has the same goals. Let's just move for improving that person to be the healthiest version of themselves that they want to be, and supporting them to do that as much as we can. And that's what I would say.
Well said. I have many a time where, as a dietitian, I sort of went in the room with a patient and started off on my whatever it was that I thought I was going in there to do. And the more I practiced and the more psychology actually that I learned, it was very important to go in and from a very neutral place, ask where they're at, because, not just for the way the patient feels when you assume, but even for the, clinician to say, you don't need to start at the basics. This is someone who's probably got more nutrition education than they do. and they may have, this particular question or area they want to dive into. And so I think that, no assumptions, be curious kind of approach from, trying to help that one individual in front of you. I think that's really wise. And I do hope this supports that approach.
I agree, for sure.
So, how can we, how can folks, if they want to learn more, I didn't give you a lot of time to talk about what you're doing. So if you want to tell us a little bit about that and how we can support what you're doing, that would be great.
Thank you. So I'm the founder and director of All About Obesity. So it's a not-for-profit organisation in the UK, and it was really just because people didn't have anywhere to go to find out about things like this new treatment options or new data. So what we're trying to do is be a platform where you can get credible information around obesity and support people to get access to that. But also, I'm quite heavily involved in policy conversations, so trying to make sure that the lived experience is brought into these conversations so that we don't just talk about obesity, we talk about it and actually realize what that impact's going to have on people living with obesity as well. So our website is allaboutobesity.org. So please come along and check us out. But yeah, just, very much work globally alongside some amazing other patient organizations, so like Obesity Canada, OAC, there's ECPO in Europe, and I think it's just about supporting us as much as you can, because we're trying to bring that voice across, and it's hard sometimes because people look at us as if to say, well, what have you're not a doctor, because I'm not a doctor, and I think I get that pushback sometimes, but I'm like, no, but I live with this condition that you're talking about, so I'm an expert by experience, and I think that you can't buy that. So I think that's really important. So please come and check us out. That would be great.
Well, thank you so much. I really
Thank you.
appreciate your time today, and I think our listeners will really value the additional, layers that you brought to this conversation. So thank you so
Thank you for
much.
thank you for the opportunity. Really
Yeah.
appreciated it.
Okay, good. We'll hope to see you soon.
You too. Take
Thanks,
care.
Sarah.
Bye.
Bye.